In this presentation, I'm going to explain a little bit about how we go about managing low back pain. So the management of low back pain, whether that's acute, subacute or chronic, will really rely upon some common factors. So the participation of the patient is really important in the success of a pain management program. So it's important, if you do suffer from low back pain, that you consider each symptom that you're experiencing and how this affects your life. So is pain your most limiting component? Is the pain okay, but you're experiencing that certain activities that you might like to do actually worsen the pain, and then you're concerned it could be causing further damage? Is pain manageable, but you find mobility is limited? Are you concerned that you need to scan and that concern hasn't been addressed by your doctor? Are the symptoms affecting your ability to work, causing financial strain? Have you any particular worries about the future? And all of these questions are really important for you to answer in terms of your experience of a pain management program. When we experience any kind of pain, we might ask the following questions like, what is this pain? Can we try and identify it? Can we think about what might have caused the pain? What consequence might the pain have? Will we have control over the pain? And how long will the pain last? The answers to these questions will obviously depend on your own unique and personal experiences of the pain, or you might know someone who had a similar pain, so that might make you think about your experience. And in this day and age, a lot of information is received through the internet and social media, so that's something to also consider. So we like to focus more on a personalized treatment of pain that's more tailored to each individual patient. And so there needs to be a discussion about more than just the pain itself. It should include an agreed goal-directed plan, and a follow-up should be incorporated into this. For example, return to work might be something you are working towards, and this is not only dependent on pain levels, but also on your mobility levels. The aim of designing a personalised treatment is to allow the person to live their life with normal work and social activities and not to be significantly limited by having low back pain. So everybody's journey, like I said, will be different, and the contribution of the nociceptive versus the nociplastic pain will vary from person to person. And in a prior presentation, I've explained the difference between the nociplastic and the nociceptive pain. And that will be different from person to person. It might depend on stress levels or levels of activity. And this is why focusing on self-management techniques early on should have a positive impact going forward. So you need to think about symptom control. Is that mainly pain for you? Movement control and the functional optimization. And then when you're planning a personalized treatment approach, the patient's views and preferences are critical to its success. And that should be discussed with your healthcare professional. So if you feel that there are certain aspects of life that is limited by your pain, please make sure that you bring that to your consultation and have a discussion about it with your doctor. So the first step in the management is going to be the clinical assessment, and I have another presentation on the clinical assessment in low back pain. And in this, your doctor will decide, like, is your pain likely to be caused by something like a bulging disc in your back, or a disc herniation, or a compression of a nerve root, or is it more likely to be non-specific in that no structural cause will be found for your pain? And really the differential between these two will largely be based on the clinical history and the clinical examination. And in the rest of this presentation, I'm going to mainly focus on the management of non-specific low back pain, but the principles apply to the specific causes too. So if you did have a compression of your nerve root in your back, the surgeon may not necessarily see that or feel that surgery would be of benefit to you, and in that case you would follow all the same principles of management that I'm discussing here. So once you've had your assessment and you've either had your scan or you haven't, depending on again what your signs and symptoms are like, you will then follow a management plan as I'm going to outline here. So pain management is now based on the biopsychosocial model, and I did discuss this in the presentation on low back pain, some facts. And essentially it means we are now looking at treating the cause of pain through the biopsychosocial lens. So this recognises that there is a non-specific nature to back pain. It identifies that there may be underlying psychological factors that can worsen pain, and it treats all of these factors with interventions that are not necessarily injections or medications. And the idea is to try to help the patient empower themselves to manage their condition in the longer term. And it just kind of acknowledges that low back pain often ends up being a more chronic condition over time. And depending on what your lifestyle, there may be times where the back pain is triggered. And so that's why you should, at the early stages of back pain, try to formulate ways of managing it that you can use going forward. So when you discuss your pain management with your doctor, your questions regarding the impact of pain on what you need to do in everyday life is really critical to the overall success of the plan. Top of that list will be addressing worries about activities that you feel will worsen your pain or that you are concerned are going to make the underlying cause of your pain worse. And so, like I have explained in a prior presentation, when it comes to low back pain, it can be broadly divided into pain that occurs just from low-grade mechanical stress. It can accumulate over time. We often refer to it as wear and tear. It happens in everybody, and it can be worse in some people than other people. And there's nothing you're doing to cause this. It's just kind of a consequence of day-to-day life. And in this situation, you may have had your scan demonstrating age-related wear and tear, but change is unlikely to be necessarily causing the level of pain you're experiencing. And this is called nociceptive pain. And then you can have pain that is amplified within your brain, and we call this nociplastic pain. And often the underlying trigger for this would be worry about the future and concerns that the pain isn't going to get any worse. And it may have led to you to reduce your physical activity levels, which then also has a further negative impact, and that's called nociplastic pain. So just kind of further developing those psychological factors, I really want to make it clear that stating that pain has a psychological component is not in any way implying that pain is imagined. And there is a misconception that anything psychological means imagined, and it absolutely doesn't. And that's been proven time and time again in the literature. And there's functional MRI studies that prove that different psychological symptoms can have a huge impact upon the experience of pain, and especially the emotional response to pain can have a significant impact upon worsening the experience of pain. So the following psychological factors have been known to make pain worse. So one is catastrophizing, and this is imagining a future that is only with pain, and as a consequence having a severe limitation on both work and leisure activities. There can be a huge amount of fear that people experience, and that mainly relates to concerns that pain signifies an injury and that more damage is being done. And then this can be compounded because patients often have to wait a very long time to see a doctor, they have to wait a long time to see a physiotherapist, they have to wait a long time to get a scan that may not even provide the answer, and then not understanding why you're having pain, but your scan doesn't really explain this. So all of this can really contribute to fear as a component of the pain experience. And then there's self-efficacy, and this is a term that is used just to describe our ability to control things in our own lives. And in relation to pain, it describes the ability to control pain and to be able to do the activities that are conducive to your normal working life and leisure activities in spite of experiencing pain. The reality is that low back pain is rarely caused by anything serious, and even if you need a scan, and even if the scan shows a compression of a nerve root or a bulging disc, the prognosis and future outlook is still really good. So the next step in management is the information you are provided with. So you should get clear information in terms of what you should or should not do, and the messages should be consistent. In the early stages of low back pain, the emphasis should be on as much movement as is tolerable. An exercise program, if being prescribed, would need to take into account what you like to do and what you're capable of doing and your preferences, because you are much more likely to engage in a program for it to be successful if it's something that you are able to do and you enjoy. Now, there are a lot of passive therapies on the market as well, like back supports and TENS machines and diathermy. Generally in the literature, these are not considered to be particularly effective. Now, if you use this and you find it useful and it's not hugely costly, it's unlikely to do you any harm. But the evidence behind them wouldn't be particularly strong. Medication is avoided if possible, but obviously that will depend on your pain levels. And if the pain levels are deemed manageable, and only you can deem them to be manageable, and allow you to move. If the pain levels are okay and you can still do some exercise, then going without pain medication is probably the better option. However, if your pain limits your ability to do stretching, to do exercise, to go to work, to engage in lifestyle activities, then taking short-term pain medication will not be too harmful. And a lot of patients are worried that medications will mask pain, and so more damage can be occurring without them realizing. But really, the important message to try to get across is that pain in and of itself does not necessarily signify that there is ongoing tissue damage or further damage happening. So there is a misinterpretation, like I said in prior slides, that pain is a sign of physical harm, and this can lead to fear and avoidance of particular activities that trigger the pain or worsen the pain, and then that can lead to a further exacerbation of pain and disability and have a negative impact upon your life, and that can lead to mood and anxiety issues because it may be impacting upon your ability to work or do leisure time activities. In general, individuals who have low back pain will note what kind of predicts their pain, and then they can learn to prevent painful events. And this obviously does make sense, especially in the early stages, but also it may not be that practical because the thing that triggers your pain might be something that you really need to do in normal life involving day-to-day activities. So even though it can make sense at the start to not do something that triggers pain, we have to try to think about how we can do this activity in spite of the pain, because you may just actually need to do this. And this can happen to a lot of patients and can lead to the disability that comes from the back pain being more an impact on disability. Having the fear of the pain can be more than the pain itself. There is some evidence that exposing someone to the movement or the activity that they fear the most might reduce the overprediction of pain, but obviously you have to be careful in this kind of situation, and you might want to do this with your physiotherapist or a doctor present or a family member, or you might want to do just kind of half the movement or a little bit of the movement and see how you get on and gradually build back up to the particular activity. And you also need to consider pain in the context of mobility. So if your pain does worsen somewhat, but you feel overall your mobility and your ability to do a daily activity remains normal, then this would be considered a positive sign. So the message that you should remain as active as possible and do activities that are tolerable cannot be emphasized enough. So something you will probably raise with your doctor or healthcare professional is whether or not you need a scan. And there can be an assumption, which is very understandable in this day and age, that if you have pain in your lower back, then you'll be referred for a scan. The scan will reveal the cause of the pain, and then there will be a way of treating the pain to hopefully end in pain relief. And if this is something that you believe to be the case, then you should discuss this with your doctor or healthcare professional. But in general, imaging is discouraged unless your doctor thinks there is serious pathology underlying your symptoms or clinical signs. If you engage in an exercise program and conservative management and you don't get any better, that may be another reason to do a scan, or there's been a significant change in your symptoms. So management of the more acute stages of back pain can be the most challenging because there is a very fine balance between rest and getting back to some movement. The general advice is to do movement that you can, that doesn't elicit too much pain. In the initial few days, this may only be possible with some anti-inflammatory medications, and like I said, that's actually okay. These have value in the acute stages of pain. It's more in the longer term pain that they kind of carry a lot of risk factors, so they become less worth it. So what you should be told when you are suffering from acute back pain is that there is a favourable prognosis, that you should stay active if you can, you should avoid bed rest if you can, and you should only take pain medications if they are needed. Now, if you don't improve, then you should be reassessed and you may need more specialised testing in that situation. There definitely is a place for medication in the shorter term of persistent and unremitting low back pain, and in the initial stages the benefits probably do outweigh the risks, but it's just more the longer term use of pain medication is what is to be avoided, as opposed to pain in the more acute stages. When it comes to subacute low back pain, again, the message to stay active becomes even more important, as the goal here is really to prevent progression to a chronic state of pain and disability. And it's really during this stage of low back pain that you could try different forms of intervention and different kind of physical activities, because you want to develop a routine or a plan that you can use should your pain worsen in the future. So again, the advice being to start with non-pharmacological ways of managing, and that means trying to avoid painkillers, but if you need them, you need them in the short term. But you might try an exercise program, gradually building it up, see how your pain responds, see what works for you, see are there certain types of movements that trigger pain and you might decide not to do those particular ones. Pilates and stretching would be a very good thing to get into the routine of doing in the more kind of subacute stages of pain, because even with the best will in the world, life can get busy. You might do a Pilates program or a stretching program and find that it's great for your pain, but life gets in the way. Suddenly you're not doing it every day, and then the pain creeps back or something triggers it. But then you know what works for you and you can just go back to it. And that is why in the subacute stage, spending a bit of time trying to figure out what works for you is worthwhile, as it may firstly reduce your chance of developing a more chronic low back pain, but if you have another episode in the future, you'll then know what works for you. For chronic pain, a lot of the same principles apply as for the management of the acute and subacute low back pain. Again, keeping physically active is really important. Establishing a stretching, strengthening, and aerobic exercise routine is very important. You might include some Pilates into that. Knowing your triggers, and I will do another presentation that specifically describes the most common triggers, but for example, if you know you're moving house or you're going to help someone move house, you're going to be doing a lot more heavy lifting than usual, yes, that may trigger a little bit of worsening of your back pain, but you could be extra focused on your stretching routine leading up to this particular increase in your activity levels, and this may counteract some of the worsening of the chronic low back pain. Good sleep and management of stress are also really important when it comes to managing chronic pain. So in terms of what to expect going forward once you've experienced low back pain, so it's important to remember that low back pain is not considered to be a serious or a life-threatening condition. There are plenty of ways of managing it that can start with the non-pharmacological interventions and non-surgical interventions. Physical activity should form a big part of your management. Spending time figuring out what works for you and what your triggers are will prove extremely useful for future back pain episodes. And pain does not necessarily signal that damage is being done and that it will worsen your overall function. So I've just put some of the references that I used in this presentation. So it's kind of the latest literature on the management of back pain. Thank you.